You must be incredibly tired. So, and I want to just thank everybody for coming. You know, we had about 210 people pre-register to come to the conference. We made 300 sets of flyers and handouts, and I think we had 400 people by the time we started. So thank you for coming. And I'm sorry if you didn't get a if you didn't get the handouts, but that's why we had almost double the number that we anticipated. I'm so glad you came to partake of this. We tried to set up a program that would give you a flavor, kind of some advocacy, the human aspect, the cutting-edge science, a really good clinical talk on fibromyalgia and pain, and really the focus of this whole conference a little bit more toward fibromyalgia than chronic fatigue syndrome, although I have to say Kathy Light's data, kind of crosses that barrier. And I want to say that as I was trying to get this talk ready, I was on the planning committee for this conference. I put myself at the end, but I don't think I did that very consciously. But as I went to prepare my talk, I became kind of discouraged and couldn't get around to doing my talk. It took me a long time to get started on this talk, and eventually I realized we have had an explosion of information regarding the management of fibromyalgia and widespread pain, and particularly the pain aspects, also on the sleep, understanding the stress component. But the reason I was discouraged, I think we've made kind of slow progress in understanding chronic fatigue syndrome. So I decided in my talk today that I was going to very literally talk about updates, and I'll just tell you some things that I think are important in the field since our last conference, which was in May of 2007. And there's really no way we can cover the field of fibromyalgia and chronic fatigue syndrome in a conference. We had a conference for providers at that meeting that was a day and a half long, and we barely touched on the aspects of what's known about these illnesses scientifically. So there's no way we can cover even everything that's been learned. But I wanted to give you a taste of what I think are some of the most important advances in the field. And, I really can't do that without giving a little bit of background about chronic fatigue syndrome and the way we look at chronic fatigue syndrome. So I'll start with that, and then I'll talk as quickly as I can. And you're welcome if you need to get up and go out and move or do any of those things, please do. And then I'll talk about the things I think that have been important in the last couple of years. And I want to preface my discussion with a little reminder that the terms fibromyalgia and chronic fatigue syndrome are a bit subjective. I think you get that. You know that because you encounter that in your everyday life, and you encounter when you listen to us try to talk about these illnesses. But these terms enable researchers to cluster people within a spectrum, a big spectrum of unexplained illness. That's my clinic. It's a clinic full of people of all different presentations of fatigue and pain, probably many different causes, many different factors, the genetic factors, the things that have triggered their illness. So these terms enable us to cluster within this big spectrum based on a major symptom, either pain or fatigue. And it's not even that simple. But when you take people with widespread pain, they don't have one cause to that pain, and they may not even be very related in the way their illness evolved, although we feel there's kind of a majority of what we call fibromyalgia syndrome that evolves with sleep deprivation and chronic stress and other factors. Chronic fatigue syndrome falls on the other end of the spectrum where the presenting and most disabling symptom is fatigue, and it may be accompanied by widespread pain or not. And again, if you take all people with fatigue, there's a large amount of heterogeneity and a spectrum of what the other symptoms may be. So the terms don't really imply a specific cause, not at this time, and they're not mutually exclusive. If you have widespread pain and you meet the fibro definition, and if you meet the CFS definition, you might get tagged with both labels to try to describe what you have. But that's all these terms are. They're descriptive terms. So the way I approach these illnesses is just be a little bit flexible and loose about how we use these terms while we're understanding the science and remembering and allowing for the heterogeneity. That means this is a great deal of difference about the way a given individual's illness would present. So I just want, and this is mostly in your hand, I don't want to spend too much time, but remember that chronic fatigue syndrome is defined by a definition, and the one we used the most was established or published in 1994, and so if you have had chronic fatigue for more than 6 months, fatigue that reduces your ability to function normally. It's not explained by any other medical illness or mental health condition, and then you have at least 4 of those 8 symptoms. That's the definition. Now, if you use that definition, that's a very big group of people. In fact, most fibromyalgia patients that have fatigue would fit this case definition because their fatigue is, it's on a spectrum. There's some fibromyalgia patients that don't experience quite as much fatigue, and they go through periods when, especially when their pain is better, that their fatigue improves. But I want to say there are a group of patients whose fatigue and their illness is devastating. High school kids who can no longer attend school, who don't really have very much pain, whose illness may start with some kind of a flu-like syndrome. So all of these people are captured under this umbrella. So this is the 1994 case definition. I think if this case definition was revised, my opinion would be to put the post-exertional relapse or post-exertional malaise symptom in the primary definition, because I think that is kind of a fingerprint for chronic fatigue syndrome. And I sort of divide fibromyalgia and chronic fatigue a little bit by how well people tolerate exercise. And it's on the spectrum, but fibromyalgia patients do benefit. You can't do intense exercise, but the more you gradually exercise and stretch and move, the better your illness gets. And yet there are a group of people on the other end who definitely relapse severely every time they bump up against that threshold. And that is a group of patients that I would consider having chronic fatigue syndrome. Now, why are these important right now? I wouldn't argue over these definitions. That's why we need biomarkers. That's why we need more work, and that's a little bit what I want to talk about. There's a Canadian definition that describes the illness a little better clinically. This first definition, the 1994 case definition, was really intended just to identify people to study. It's a research case definition, so we can't get too hung up on that either clinically. And there's also a pediatric case definition that follows the pattern of the Canadian case definition. And the things that are different about the pediatric case definition you may recognize in people who you know who are younger. You can use the definition sooner, after 3 months. The fatigue is more likely, or the illness is more likely to be relapsing than continuous. A lot of times they'll go in and out of the symptoms and look like they're doing better and then crash down. And also in the case definition, they can have either sleep disturbances or pain issues or both. So sometimes not as many symptoms are present in the young people. But they have neurocognitive symptoms and then autonomic, neuroendocrine, and immune symptoms. So let me tell you, before I talk about the advances in the last 18 months or 2 years, that we really know a lot about chronic fatigue syndrome. The problem is none of these are very useful biomarkers. We can't go to do a lab test, but we do know many things. And PubMed is a search engine on the web for looking up research articles, and there are more than 4,300 peer-reviewed scientific publications about chronic fatigue syndrome in the literature. In fact, there are 467 since January of 2007 in the last 18 months. And for fibromyalgia, there are 4,800 in the literature and 667 for the last 18 months. So you can see the literature is full of good science while we're trying to understand these illnesses. We know from good studies, and I'm going to tell you about these population-based studies, that there are between 1 and 4 million Americans who fall under that case definition. That is a huge number of patients. We know from good studies that the annual direct cost per patient, and this is based on a very conservative number of 800,000, not 1 million or 4 million. This is an early study, though they spend between $2,000, $8,000 extra a year on medications, medical visits, labs, tests. I'm sure you can all relate to this. That equates to 2 to 7 billion per year just in direct costs. If you add indirect costs, meaning loss of productivity, inability to work, household productivity, the direct and indirect costs are estimated to be between $18 and $24 billion per year in this country, just from people, just the case definition of people who meet chronic fatigue syndrome. This is a huge, huge public health problem. We know that CFS is not just a form of depression. We know that, and this is based on published peer-reviewed studies, we know there's low-grade immune activation, abnormal natural killer cells, pro-inflammatory cytokines. We know that there's evidence of active or latent active infection with various types of viruses, particularly in the herpes virus family, enteroviruses and other pathogens, and I've listed a few there. Our ability to measure them is still pretty rudimentary. We think they're there or that they're causing a response in the immune system. If this is a primary or secondary issue, we're still not sure. We know that studies of the brain are abnormal in patients with CFS. On MRI scans, SPECT scans, PET scans, and in neurocognitive testing, we have a huge amount of data supporting the fact that this is a centrally mediated process. And there's a lot of overlap. You'll hear overlap with the way we define fibromyalgia syndrome. And remember, they're not exactly mutually exclusive. We know that the hypothalamic pituitary axis, or the HPA axis, is blunted and dysregulated, the neuroendocrine system. And this is part of our stress response system, the physical response to stressors, and physical stressors and psychological stressors. And its co-partner in the stress response system is the autonomic nervous system. And Kathy's data showed some, and she didn't go into it too much, but some relationship to the autonomic nervous system. And we know that patients have autonomic dysfunction, orthostatic intolerance, and tachycardia and problems maintaining blood flow. And these are very important systems for allowing the body to respond to daily stressors. And it's hard to know how much of this was the beginning, how much of this is the chicken or the egg, and then how much this problem contributes to additional problems. So this is a very complex system involving immune mediators, neurotransmitters, neuroendocrine factors. It affects the central nervous system and all the parts of your body that the central nervous system controls. The musculoskeletal system, gastrointestinal tract, your immune system, your circulatory system, and the HPA axis. And there are many risk factors, and Dr. Smith talked about some of those. And it's a complex system, and it's very difficult to measure. He used those examples about the very most predominant symptoms of fibromyalgia we don't have very good objective tests for, even though we know they're there. So we have a lot of information to show that CFS is a real problem, and it's overlap with fibromyalgia. So let me tell you about some things I think are important that have happened in the last while. I'm going to start talking about epidemiology and genomics. Now, maybe you've heard about the Wichita study. This was actually done about 10 years ago, in the late 1990s, using the 1994 case definition, and this was the study that showed that at least 1 million Americans are affected. It's where those cost estimates came from, and then you may remember, and I think we talked about this in our last conference, or in one of the education meetings, that the CDC used the data from that study to do a major computer and mathematic evaluation of all the laboratory tests of these patients. And 33 papers were published in 2006 using genomics and just major and great information, a big amount of press response related to these studies. Well, what most people don't know is the CDC went on and began another study in Georgia. And they used a little different definition. I'm going to talk to you about this. This study suggested that up to 4 million Americans are affected by CFS. They looked at patients in metropolitan, very, very large cities, urban areas, and rural populations, and they're going to start to identify and follow patients with CFS. No one's done that. No one's looked at patients with CFS and followed them over time and gathered them into clinics. A clinic like mine just doesn't exist anywhere in the world. I shouldn't say that, but it's very rare to have a clinic just devoted to evaluating these illnesses. There are many fibromyalgia clinics. Rheumatologists are looking at fibromyalgia, but there are very few clinics. There are others in the world, very few in this country, that just gather patients with chronic fatigue syndrome. So this is a very important beginning to put people together, and they're going to try to form a CFS registry. I want to tell you a little bit more about that. So let me tell you how they did this study, just to give you a sense of the enormity of a population-based study. They called 11,000 households in Georgia, talked to 19,000 people. 6,000 people had a 30 to 45-minute computer-assisted interview. They identified 2,000 well and 4,000 unwell people that underwent these interviews. 783 people met the CFS case definition over the phone. That's with no medical evaluation, but by the sound and the symptoms of their illness. Those people were all invited for all-day evaluations where they were tested and evaluated by physicians. Of those people, 282 were excluded. Of the remaining 500 people, 124, this is after exhaustive evaluations. Remember, they started out with 19,000 people. 113 people had chronic fatigue syndrome. 264 were unwell but didn't have a diagnosis and didn't fit into the niche. And that's where projections came that perhaps 4 million Americans meet this criteria. That is a huge number of people. You know what else they found? Is another 4 million people were sick but had an illness that had never been diagnosed. It was a treatable illness. So we also need to get to those people who might have chronic fatigue syndrome or fibromyalgia, do not have access to good medical care, and perhaps could have their symptoms resolved with good attention and care. They're going to take these patients that have been identified in the Georgia study and carry out some additional studies. It's called Pathophysiologic Mechanisms of CFS, Neuroimaging, Neuroendocrinology, and Genomics. They're going to admit these patients for 3 days of testing, extensive testing on your tax dollars, only a few of your tax dollars. They're going to do functional MRI scans and brain studies and questioning and all kinds of lab evaluations, hoping to understand more about the HPA axis, the autonomic nervous system, and what might be going on in these patients. They're also going to begin a registry. I just alluded to it in an earlier slide. They're going to take these patients and begin, they're going to keep a list. They're going to keep a record of everyone who's been diagnosed with CFS in the study. Not only that, they're going to recruit physicians throughout Georgia, both regular physicians and also practitioners of complementary and alternative medicine, to refer the names, of course with the patient's permission, but refer the names of all the people they encounter that they think meet the criteria for CFS. They should be able to get thousands of people in a registry in Georgia. That's going to enable them to get a large number of people together to study, to do research. They're near Emory University and the CDC scientists, and they're going to be able to follow these patients over time. This is the first time that anyone's taken an interest in identifying a population and studying them over time. This is huge. It's going on quietly, and it's possible they're not going to be funded and they're not going to be able to finish this because of large amounts of budget changes going on and the lack of funding for the CDC. But I think it's important that you understand this is going on and that there's an effort to continue it. I want to go back to the Wichita study, the first population-based study that the CDC did. They also took patients. This is after a while, after they'd done other studies on the patients, and they admitted them to that hospitalization. And they looked at, this is just a diagram, they looked at some 55 patients who did not have fatigue. This was a smaller scope study than the Georgia study. 58 CFS patients, 27 patients who had CFS and depression. Didn't quite meet the research case definition, but of course anybody with CFS can also develop depression. They didn't want to exclude those patients. They looked at patients with insufficient symptoms of fatigue. So they looked at people who were sick but didn't quite meet the full case definition, and also those patients with depression. So you can see that they looked at a number of patients. What was most important and I think pivotal were their genomics study. This is called microarray technology. And I just wanted to briefly, this is a technology used in other diseases, not just CFS, but it's moving us forward in learning to understand how to understand the mechanisms, the pathophysiology, and develop treatments for illness. We now know the entire human genome. We can take bits of the known human genome, parts of them, and put them on slides and use them as templates to compare normal samples. So these are commercially made and sold, and that's what you see here on the left. We can then take a blood sample from, or many blood samples from people who fall in the group of an unknown illness like chronic fatigue syndrome, extract the RNA, and they label it, and then they put it in together with the normal template, and it can be analyzed by computer analysis. And they look at these, this is not my area of expertise, but they look at these genomic studies, and they can compare how every gene is functioning in the sick patients compared to well patients. Now, this is a huge endeavor. There are so many of these genes, and they have to be analyzed by computer. But they can tell if the gene is producing more of its proteins or its product or less, upregulated or downregulated. And then the computer can try to associate and do all the math and show which ones are different in the patients and in the controls. With this study, they were able to, using high-level mathematics, show that the gene product of chronic fatigue syndrome patients was different than the non-fatigue patients, and that those people with insufficient symptoms of fatigue fell somewhere in between. And this was a very, very important piece. You know, you could not look at the lab tests. All the lab tests looked normal. But they took these patients and did these expensive studies, and this just hit the press back in 2006, if you can remember. They were able to show that a very heterogeneous population could be broken down into groups, depending on the way these genes broke out and associated. And these different groups were associated with different gene products. I'm giving you that background because in the more recent times, and I think they're getting ahead of us here, Dr. Jonathan Kerr, who's in London, and there's also other groups doing genomic studies in chronic fatigue syndrome, he took the RNA blood samples and looked at microarray analysis, 25 patients with CFS and 50 healthy controls. Then he did what's called PCR to confirm his data in a little bit larger group, 55 CFS patients and 75 healthy controls. He was able to show there were 88 genes that seemed to be functioning differently in CFS patients than the normal control patients. And those genes clustered around several kinds of functions: hematologic disease, immunologic disease, cancer, programmed cell death, immune response, and infection. I can't fit this on the slide very well, and you have to go to the article, but these are mathematical models of these genes showing up and down regulation, clustering according to the kind of genes. You don't need to understand this. I can understand this, to be honest. What's important is once we know this, new studies will be done to try to understand what these groups of genes mean, and we'll be able to subset patients. There were 6 subtypes suggested by the early CDC studies. Dr. Kerr's studies suggested 7 genomic subtypes in the patients he looked at, in those differential expression of 88 genes. And you know, it's interesting, look at these 7 subtypes, and those of you who have illness, do you see yourself in any of these specific subtypes of patients? And I think there's overlap with fibromyalgia, post-infectious fatigue, many different causes may sort out. So that one group had cognitive, musculoskeletal, sleep, anxiety, and depression. That sounds a lot to me like a big group of people with fibromyalgia. Number 2, musculoskeletal pain, anxiety, and depression without the cognitive symptoms. There were a group that had milder symptoms, a group that was mostly cognitive dysfunction, a group that was more muscle pain and GI pain. You can see that he was able to sort patients mathematically into several groups. So I guess the importance of this is genomic studies are moving forward. And we have to be patient. This does not translate into diagnosis or treatment for you right now, but it's creating an important foundation for the next stage of science, and it's going to help us subset these illnesses using biomarkers. That's really the next subject, and these are kind of a little bit overlapping, but I think the most important movement in the last period of time has been the search for a renewed emphasis on looking for biomarkers. And microarray gene expression profiling that we just talked about is probably the most important foundation for biomarkers that we have. But I wanted to mention that in 2006, when the NIH funded 7 groups of researchers, there really had been very little funding for CFS at all. And due to a lot of political pressure and other reasons, they came up with $4 million, which may sound like a lot of money. They had a request for applications, and many, I think maybe more than 40 applications came in for research projects, and 7 researchers were divided. 7 groups with important studies divided this money, and Kathy Light's group was one of those groups, the 7 groups of people who got this special money from the NIH in 2006. I just think this is important because this is our research going on. This is it in CFS. And we're there. So you just heard some of the most preliminary results of this really important work for biomarkers from our local group, who have probably maybe a step ahead in bringing out their data from these other groups. I wanted to briefly tell you, not about all the groups, but Marianne Fletcher, who is the lead requester on there, and Nancy Klimas are studying neuropeptide Y and CD26 in CFS patients. And this summer, Nancy Klimas presented data at the June 2008 Symposium on Viruses, suggesting that CD26, which is a marker on immune cells and is associated with natural killer cells and may work together with them, is definitely lower in patients with CFS. It's a cheaper test than trying to do natural killer cell tests. Those of you may know that it's a test that can be done, but it's not standardized from lab to lab, and we don't usually do this test. But, her slide's not going to show. Anyway, I had a slide here that showed her data, that just showed that the CD26 cells were lower in the group of patients with CFS. And that's a borrowed slide from Nancy. Just gives you a little heads up on her data. There are two other studies, one at Georgetown that's looking at proteins in the spinal fluid they may be specific for CFS that we can study, again, to subset patients or look for to use as a biomarker. And studies at Vanderbilt, this is very important, studies a patient's autonomic nervous system, doing tilt table testing and trying to understand about orthostatic intolerance. So you see these areas of pain, immune function, sympathetic nervous system. The CDC is doing HPA axis studies. When these pieces come together, we're going to have more information. Those of you who are in touch with the CFITS Association may know that they set a goal. I'm on the board, and I think I was the one that said, no, you got to do $1 million. I think they wanted to try to raise $500,000. I said, don't stop there. We've got to raise $1 million, and the board agreed. They made a goal to raise $1 million, and I want to tell you that they've reached that goal. In the last year, all of that money will be devoted to competitive studies for biomarker research. I have to say they made this big emphasis to raise $1 million for research, and they kind of need to work now on raising their normal money to run the organization. So if you want to donate, please send some money to the CFITS Association. They really need it right now. Okay, now I think, and my time is short, but the other parts are shorter stories. There was a conference this summer in Baltimore that I was able to attend where researchers from around the world came and presented their data about viruses and chronic fatigue syndrome. It was very interesting. I have to say that we didn't come away with any new biomarkers or any concrete evidence, but each of these researchers came and brought evidence in their area of expertise: HHV6, Epstein-Barr virus, Q fever, Ross River virus, enterovirus, parvovirus, Bonavirus, which is actually an animal virus that is not known to affect humans. And we all know that Candida can be increased in patients with immune dysfunction. All these researchers came together, for the first time I know of, in a conference just to talk about viral infections and CFS, to share their data, try to look for commonalities, and see if we can understand what's going on better in patients with CFS. Each one of them had data to show that the presence of these viruses was higher in CFS patients than in normal controls. There was also a very interesting discussion about the idea of a superantigen and as a trigger for CFS, and there is research going on looking at human endogenous retrovirus K18, which is an old, many generations ago, viruses inserted in our DNA. We all have it, just a passive writer in our DNA. And it's possible that when we encounter, and in fact, this is part of that genetic predisposition that Dr. Smith was talking about, it's possible when we encounter a virus, maybe like Epstein-Barr virus, that 90% of people get in their life, that it triggers a response from that virus particle that's embedded in our DNA, releasing proteins or activating a process that really is only indirectly related to the EBV infection. So this is another area of research that's being pursued in trying to understand why people develop post-infectious fatigue. Why is it that someone, vigorous, healthy, productive person, can develop some kind of an infection and never recover? That question has never been answered. And it's a very, very important question. And as I see a lot of young people, teenagers and people in their 20s whose lives are devastated. And we have very few tools, to be honest, to modify their symptoms and improve their function. And we need to make much better progress. You may know about what's called the Valsite trial being done at Stanford. Jose Montoya is a very wonderful, compassionate infectious disease physician who started seeing CFS patients in his practice and realized that some of them improved on antiviral drugs. So he did a review of his cases and was able to get funding from the drug company that makes Valsite, and carried out a double-blind placebo-controlled trial. Unfortunately, the results are not in yet, but he did come to the viral and CFS conferences, viral diseases and CFS conferences, and presented his early data, suggesting a statistically significant improvement in cognitive function in the patients, but unfortunately, it was pretty small. They had only looked at some of the studies, though, and they have many more things to look at, including treadmill testing, cytokine analysis, genomic studies, and viral markers and other things that we can hope to hear from later. And I think they hope to do a larger study as well. I wanted to mention someone I'm very proud of, Peggy Allen, who's here among us. Peggy, where are you? She's back there. Just to highlight what an individual can do. First, I have to tell you, this is Lauren, her daughter, one with the arrow pointing at her, and Lauren's dog. And Lauren is affected by chronic fatigue syndrome, and I can tell you that because she wrote an article, wrote an editorial in the paper a couple of years ago and talked about what it's like to live with her illness. And her mother, who's a medical professional, would give anything to help her daughter become whole again. But what she did was decided she would contribute to the literature, and she recently had a paper published called Chronic Fatigue Syndrome, Implications for Women and Their Healthcare Providers During Childbearing Years. This paper is excellent. So any of you who are interested in this aspect of chronic fatigue syndrome, as it applies to women in childbearing years, you should try to get a hold of this article. It's in the Journal of Midwifery and Women's Health. If you don't take that journal, it might be a little difficult for you to read the article. And Peggy can't tell you this, but I can tell you a couple of ways you can look at this article. So there's an excellent summary of the article. It's a bit meaty. So some of you might like a summary of the article, and I put this should be in your handout. And there's sort of a full text of the article borrowed by CoCure, the listserv. If you want to, if you can see this on your handout, you can go on the internet and look at the whole text of the article. But this is an excellent reference. What she did is reviewed the entire literature of chronic fatigue syndrome, detailed what we know and what we don't know. It was a very exhaustive and extensive discussion, very courageous, and most of all, she said what we don't know and how much we need to learn, especially as it relates to women in childbearing years. So thank you, Peggy. And mostly, I want to inspire everyone. We all have different ways we can help, and we need to help in the ways that we can. Right now, there really is not much more I can say about treatment. I don't have anything new to say about treatment of chronic fatigue syndrome. And I've given a lot of talks about treatment, and you heard some excellent advice from Lee Smith about what we know about treating pain and sleep. And there are many other resources, but the way we manage the CFS right now is mostly by pacing and activity limitation. We try to improve sleep, improve mood and cognition, try to manage severe pain. We work on helping people not be so deconditioned, try to support their orthostatic intolerance, and do everything we can. But, this just means we don't know how to treat this illness, right? We can offer supportive care, and you need to have that. It's very important. But these kinds of supportive care this type of supportive care does not really change the course of chronic fatigue syndrome very much. It improves quality of life, and it helps manage symptoms. I thought I would comment on Ampligen, which is the only drug in development for CFS right now. It's an immune-modulating antiviral drug. It is in the bowels of the FDA somewhere, and no one knows when it will appear with an approval or lack of an approval. I think it will probably be approved. I don't have any information, no inside information. My gut feeling is I think it will be approved, but we'll find out. And I've heard rumors that we might hear in the first quarter of 2009 what the disposition of this drug is. Just wanted to say a word. I know our conference is over, but there's a conference. The next international scientific conference is going to be in Reno in March. There's going to be an associated patient conference. But the most important thing we need right now is we need more money to fund research for CFS. And just last week, I just brought up 2 points for comparison. The Jerry Lewis Telethon raised $65 million this year for muscular dystrophy. There are 200,000 people in the U.S. with muscular dystrophy. There are 2 to 3 million people in this country with breast cancer. The Susan G. Komen Foundation, this is a nonprofit that holds races, lists contributions of $242 million in 2007, and the NIH spent $690 million. I am glad that they spend all this money on breast cancer research, but I want you to contrast that to the funding for CFS research. The NIH probably funds, it's hard to say because they don't really like to fund CFS research. They fund related type illnesses and don't actually say CFS. Probably $3 to $7 million per year. The CDC is down to $5 million a year from a top of $9 million in 2005. They're only able to spend that much. That's why I'm not sure they'd be able to complete the CFS registry or to complete the Georgia study that they have planned. The CFS Association has worked so hard to be able to raise $1 million, but that pales in comparison to the kind of money that's raised for other illnesses. And what's miracle right now, unfortunately, is what for good or for bad, most of the progress in fibromyalgia research has come from pharmaceutical companies who've developed drugs to manage pain and sleep. And I'm grateful for that. And that is what's been the huge surge forward for making progress in fibromyalgia. I would like to see the same kind of a surge of interest in funding for chronic fatigue syndrome. So with that, I hope that isn't too depressing. I'm so excited about the progress we've made in managing fibromyalgia syndrome and the way that helps us manage chronic fatigue syndrome better. But we need more research and we need more funding, and here's some good resources for you. I hope they're helpful.